Hello and welcome to our fourth in our MDT Spotlight webinar series. Delighted to have you with us today. I am just going to share my screen. Here we go. Great. So yes, big welcome to you. And we're really delighted to be focusing on speech and language therapy for today's session. I know that hopefully you'll have seen some of the other sessions already that we've run. But yeah, really delighted that we're going to be focusing on this particular specialism for today. A few intros before we get kind of kick-started. My name's Chelsea Letts. I'm the Healthcare Engagement Programme Lead at the charity Bliss, and I'll be facilitating today. I'm really pleased to welcome Alex and Rebecca. So Alex, would you mind just introducing yourself, please?
Yeah, of course. So my name's Alex Connolly. I'm the clinical lead neonatal speech and language therapist at Imperial College Healthcare NHS Trust. And also I am one of the SLT network leads for London Neonatal ODN.
Lovely, thank you. And Rebecca?
Hi, my name's Rebecca and I am clinical lead neonatal speech language therapist at King's College Hospital. And I'm currently also doing an NIHR pre-doctoral clinical academic fellowship. And I'm really pleased to be here. Thank you.
Lovely. Thank you both so much. We are really pleased to have you as the expert today to kind of share your knowledge and wisdom. So thank you in advance. So today's session, we are kind of jam-packing this into an hour. It is going to be recorded, so we'll be able to share this recording afterwards. And we are going to be hearing initially from Alex and from Rebecca, just to give us a bit more context and understanding about the speech and language therapy in neonatal context and what that looks like and what it all means, which will then help us kind of talk a little bit more about that through some Q&A afterwards. We are hoping to have a parent with us as well today to kind of share a bit more of her insights and her experience working with speech and language therapy when her son was on the neonatal unit. We've tried to incorporate any questions that were sent through in advance through the registration form into the session, and we will hopefully have a bit of time to look at the Q&A during the session. There should be options for Q&A and chat. Please do use the chat for any queries or questions you might have about tech, or you want to chat with the Bliss team about anything in particular, and feel free to use the Q&A part of the functionality on this team session for any questions that you might have for Alex and Rebecca, and we'll try and keep an eye on those and make sure that they're incorporated as and when we can. So just before I pass on to Alex and Rebecca, I just wanted to say kind of a bit more, which I've done kind of in each of the sessions, but I think it's really important to start off thinking about why we're doing today. And I think we want to make sure that as an organisation, we're really advocating for these roles and for trying to increase awareness and knowledge of what these different specialisms look like. And obviously, speech and language therapy is our main focus for today. We want to support you as healthcare professionals to support how these roles are integrated into the wider neonatal team, and to highlight how important they are in the delivery of family integrated care for every baby, which we know is a big driver at the moment. And there are challenges, we know, with the various different allied healthcare professional, psychology and pharmacy professions in terms of some inequities, in terms of what service might be available. But I think it's really important that we're still highlighting kind of where these roles fit in, how they can impact on families' experiences and the baby's experiences, and improving that parental partnership, and obviously always we can see the growth in these roles as well, being kind of available more and more, which is fantastic. So really important session today. I'm going to stop sharing without further ado, pass over to Alex and Rebecca, who are going to give us a little bit more background, I think, into what speech and language therapy is all about.
Great. Okay, so I'm just going to share some slides. There's just a few to start with.
Just while Alex is sharing those, we just wanted to start by saying thank you to Katie Parnell and Joe Marks, who've helped us prepare the content for this webinar. So we just want to say thank you to them. And of course to Sophie, who's going to be joining us a little bit later, talking about her and her son Xander's stay at a local neonatal unit in London.
Okay, so what we thought we'd start by doing is just setting the scene a little bit and providing a bit of context. So both Becca and I are clinicians, we're neonatal speech and language therapists, but we also have dual roles. Becca's mentioned her PCAF fellow role, and I'm also one of the London ODN SLTs. So we just thought we would start by talking about the ODN roles and how this impacts what we do. Oops. Okay, so I'm going to reinforce some of the key messages that the other neonatal AHPs have raised in their presentations. It's just to say that our network roles basically came about following something called the Neonatal Critical Care Review. This was a recommendation that each region should have a lead in each allied health professional and psychology profession. And this would really have this role, these roles have a strategic overview. We all have an overarching shared theme, and it links a little bit to what Chelsea was saying just before. So it's that kind of reducing inequity. So if you're a parent, you know, no matter where you are, which unit you're on in that region, you should have the same experience, access to the best practice, and also we all share the overarching role of trying to increase provision within our area. And so in 2022, when these network roles started, one of the very first things we were asked to do was to benchmark, and that was to really identify what our current SLT provision was like in each region and where the gaps lie. And we'll have a little look at that in a moment. And I'm just really not going to read through this whole slide, but I'm just going to pick some key bits. So we facilitate neonatal teams to really think about their SLT provision and what their next steps are with their workforce plans. And this might mean supporting business cases and the recruitment process. With education, we all play a really key role with the network education strategy. That might be creating the strategy in a multidisciplinary way, or teaching on the programs, the network programs. And there's a particular focus for nursing staff as well. So this is all levels, be it foundation, QIS, and enhanced neonatal teaching as well. We across the country provide peer supervision groups, and this is just to make sure that neonatal SLTs on the ground are connected with their peers for that clinical support. From a clinical governance perspective, we might be involved in writing, producing guidelines, contributing to multidisciplinary guidelines. I know in some regions they've had pilot projects looking at, with charity funding, you know, to see the impact of having an SLT on the unit, or supporting quality improvement projects. And just like we're doing today, a lot of the work that we do as network leads is to raise the profile and awareness for our profession. And so that will be attending events like today, producing clinical resources that can be shared, conferences, and social media and website development. And just to add, that each region has different needs and priorities. And so the work that takes place by your SLT lead will really differ depending on what's needed in the region. And then we basically just individualise our support and tailor it to the needs of the different networks. Over to you, Becca. Oh, no, one more for me. And so this just highlights the gaps basically in our workforce. So you can see the blue part of the bar chart is indicative of the previous SLT provision, we had some funding across all professions from NHS England, and this was a welcome uplift for SLT especially. And however, so this is in the orange, however, you can see by the grey part of the chart that we've still got significant gaps in our workforce when we compare this to what's recommended in our neonatal SLT staffing recommendations. So this is what's going to keep all of the SLT leads across the country, the network leads, very busy.
So this is my slide. So this is a really nice slide that was created by the London Neonatal Network, which kind of explains in brief what a neonatal speech and language therapist would do on the neonatal unit. So you can see there the first kind of stepping stone is supporting a feeding relationship. And obviously this is very much at the heart of what we as neonatal speech and language therapists do. So we're very much supporting that feeding relationship initially by supporting pre-feeding things. So maybe we encourage skin to skin, true and consistent skin to skin, but then we'll kind of go on to support parents with whatever feeding route they choose, whether or not that be breast or bottle feeding, in a kind of cue-based way, and so that parents feel really confident in how to feed their baby, not only when they're on the neonatal unit, but then when they leave. Another area that we support with is lactation and breastfeeding. So many speech and language therapists are now becoming dual qualified IBCLC lactation consultants. And this very much means that we can then support the parents and the babies in terms of kind of latching and positioning the baby at the breast. And when we're able to do that, then we can then set ourselves up for a much smoother assessment of the baby's feeding and swallowing. We also support with regards to language and interaction. So this is like at the core of what a speech and language therapist does, and this doesn't stop when we get on the neonatal unit. This is very much part of our role in the neonatal unit as well. So supporting parents to read their baby's cues and respond in a way that supports their kind of language development across everyday tasks such as nappy changes, bath times, feeding. We also promote positive early oral experiences, and this could be in the form of non-nutritive sucking. So there's lots of new kind of evidence out there that talks about the benefits of this, but also around tastes and positive smells, such as kind of using oral cares, using express breast milk to kind of carry out oral cares. We'd very much be kind of supporting that and showing parents and staff how to do that on the neonatal unit. And then moving from tube to breastfeeding as well, or bottle feeding, moving from tube to oral feeding, should I say. Obviously, that is another kind of key part of our role, supporting parents and staff to read the infant's feeding cues and support them in that transition, making sure that it's very much in a baby-led way in order to achieve the most kind of positive outcomes for the baby. Obviously, feeding and swallowing assessments, that's what we're best known for probably on the neonatal unit. And so we will carry these out, kind of specialist individualized assessments of infants feeding and swallowing for the more complex babies that are on our caseload. And then offering support, like I've said, around cue-based feeding support. So again, more of an education role with regards to this, kind of supporting nursing staff, medical staff and parents, and modelling how we would do this, kind of supporting an infant's feeding while reading their cues. And this is just kind of an example of the type of service that we offer as a speech and language therapy team on the neonatal unit. So kind of across speech and language therapy, we kind of work in this kind of universal, targeted and specialist kind of pyramid. So I'll just talk you through what this means with regards to speech and language therapy on the neonatal unit. So in the kind of universal kind of section, that's kind of relating to things such as education. So making sure that we can support as many babies as possible on the unit by educating parents and staff with regards to things like cue-based care, supporting early language, supporting preterm feeding and positive feeding, so that type of thing. We also kind of in this section would be involved in audit and QI projects, and this can be specific to speech and language therapy. So it might be around creating a positive feeding environment or mouth cares, or it might be a little bit more specific to the neonatal unit and what they're working towards. So things like BFI, it might be that we'll be supporting them with that. We'll also be offering parental support as part of our universal package. So it might be that we kind of set up parental groups. I know in a unit that I work on, we've set up some really nice parent coffee mornings. So it could be things like that, making sure that we kind of add to the parent education in that way, as well as kind of staff education. And again, this could be through kind of cotside teaching, or it might be through things like newsletters and developing resources. And obviously all of this is then underpinned by our best practice models, which you can see on that side, on the right side there, such as Baby Friendly Initiative, the developmental care kind of model, and the FI care model. And then in the next kind of layer up, the targeted layer, you have kind of the screening and surveillance of our high risk babies. So it might be those babies that are born particularly early, so less than 30 weeks, or particularly low in birth weight. So we'd be kind of screening those as we know that these are our high risk babies. It might be that we're having cotside conversations around these high risk babies where we can offer additional support with regards to kind of pre-feeding or early communication. It might be targeted ward rounds, such as our developmental care ward rounds, or it might be more speech therapy specific, so our feeding or ward feeding and nutrition ward rounds. And then obviously inputting into kind of guidelines across the unit as a whole. And then finally, we've got our specialist section there at the top. And that's very much kind of our one-to-one specialist assessments and management of our more complex babies. So those babies that have neurological differences or airway differences that need a more kind of in-depth kind of assessment of their feeding, swallowing and communication. I think, is that all of our slides?
Yeah, so that's our slides all done. So we'll stop sharing now.
Thank you both so much. That was really helpful, as I say, to kind of give that background understanding, increase our general knowledge about what speech and language therapy is all about, and really, really helpful to see that model, just understanding kind of how that works and how speech and language therapy is relevant for every baby, and like depend, like obviously regardless of need. We had a quick question actually from somebody in the chat just asking whether you would be happy to share the slide, I think with the footsteps, so that with the kind of an outline of what speech and language therapy is. I don't know whether that's available to share kind of more widely.
Yeah, absolutely. We've been tinkering with that poster on and off for a while, and it really is ready to let go of it now and share it. So anybody who wants to use it is very welcome.
Brilliant, thank you very much. I think we'll dive straight into some questions. I think Sophie is on the call, which is great. So I think we've got an opportunity. Hi, Sophie. Lovely to see you. We've got an opportunity, I think, in just a moment to kind of really get more of an understanding of your own experience, Sophie, if that's okay. But I think initially, I'm just going to start by asking Rebecca, you mentioned just now in the slides you were just talking about the role of language and interaction, and I wondered if you could just tell us a little bit more about when babies might start to develop these skills and why that's important kind of as part of your role.
Yeah, I mean, that's a really good question because it actually starts really early on, probably earlier than a lot of people would think. So in terms of supporting that language development, it's very much about developing the baby's attention and their hearing, I should say first, attention, and then that language input. And then with those things, the baby's then able to support and develop their language and communication skills. So thinking about the baby when they're in utero, in terms of the structures, a lot of those are in place at around about 23 weeks, so really early on. And then from about 25 to 26 weeks, the baby can start to process and react to sounds as the cochlear hairs begin to develop. And then a little bit on from that, so around about 26 to 28 weeks, the baby's then starting to demonstrate responsiveness to voice. And then from 30 weeks, the baby's starting to show those active listening skills and starting to demonstrate attunement, particularly to the maternal voice, which is really lovely. And infants initially are reflexive in terms of their responses, but this does become more kind of reactive to the events and the people around them. And then they start to become more familiar with their environments and those around them, and then start to become anticipatory. So you can really see then how that starts to develop from kind of early on until the baby becomes close to term.
Yeah, much more of a journey, I think, than maybe definitely that I realised. So thank you for giving us a bit more information about that. Really appreciate it. I think there are a couple of posters I think that I'll pop in the chat. Is that the bit that's relevant? So I'll pop a couple of those in the chat in a second, just in case they're useful for that you kind of sent across in advance. So I'll do that in just a second. Alex, I wonder whether you'd be happy to tell us like something kind of, we've obviously heard a bit more from you both about what speech and language therapy looks like on a neonatal unit, but is there something in particular that you really want to share about it, about your roles that we probably wouldn't know that you think would be useful to share today?
Yeah, there's a few things. I suppose we could start by just talking about, I think Becca's already touched on the wider role of the speech and language therapist on the neonatal unit and the different ways that we work. And I think that's probably the bit that might be the most different. You know, to some people, they might never have had neonatal SLT on their unit, or they might just have had, you know, just half a day or something. And so that might feel or sound really different to what you're used to. And what we know is that with basically increased time, we are able to have more of a presence on the neonatal unit, and that just means being involved with the developmental journey for the baby and the family all the way through. And we know that just that early involvement really supports later outcomes for our preterm babies and babies born on the neonatal unit. And so all your neonatal SLT on your unit would be more than happy to kind of talk about how that would work on your unit and how it would fit with your team. But yeah, it's that really early involvement and the involvement in the whole journey. Other kind of things that people might not know is that actually we've got a growing number of SLTs who are clinical academics. And so what this basically means is that they are neonatal SLTs, so they're clinicians on neonatal units or have been, and they're also researchers. So this is really positive for us as a profession, because this means that we've got people on the ground who are identifying where we have gaps in our evidence. And then, you know, they're able to spot maybe some problem areas that we experience. And then they're able to go away and research these areas and bring it back to the unit SLTs. So that's so positive, because then as unit SLTs, we can basically bring the latest evidence-based practice to the COT side and share that with families as well. So that's a bit of an exciting thing for neonatal SLT. Also, I suppose, just in line with what Becca was saying about dual qualification. So we do have a number of SLTs who are neonatal SLTs and lactation consultants. And maybe it's just helpful to think about, like, how does that work with a neonatal team? What would that look like on your unit? And again, just reinforcing what Becca said, it just means that, you know, those babies who are identified as needing SLT, who might be more complex and they're breastfeeding, it means that we're able to fully support that parent and family, you know, however they choose to feed, basically. It also means that we can more easily champion the principles of BFI, so that's the Baby Friendly Initiative, and have those kind of early of support. It's always part of a team, so it's never just kind of like an individual approach. How it looks will differ because depending on your skill mix on your team, on your unit's priorities, but it really is about having those early conversations as part of a team. And it really is, with lactation and breastfeeding, the more positive messages about these things that we can be reinforced by everybody, the better the experience is for the baby and the family. Have I got time for one more?
Yeah.
Do you think?
A quick one.
I could go on. Okay. Well, I suppose it's just the transition aspect, you know, that we're always thinking of the baby's long-term journey. So it's not just about when they're on the neonatal unit. We're aware that what we're doing on the neonatal unit is supporting them when they go home as well. So that means, you know, again, that big focus on development, but also really close links with outreach, our outreach neonatal nurses, our community teams, because we know that for preterm babies, speech and language difficulties and feeding difficulties are prevalent. So it's just about thinking about the whole journey, about that transition for the baby and the family, and building confidence at that starting point, so that they can continue with that when they go home.
Brilliant, thank you, Alex. There's loads, I think. No, I think there's loads, and I think we could definitely do kind of full days on this on each of the specialisms that we've done. But that's a really helpful taster. Thank you so much. I think at this point we would love to introduce Sophie to you all. Rebecca, I don't know whether you know Sophie, so I wonder whether you'd like to do a little intro, and then Sophie can talk a bit more about her experience.
I do know Sophie. She was one of our wonderful parents that we had on our neonatal unit. I'm not going to say too much. I'm going to allow Sophie to introduce herself and Xander and about their neonatal stay and the impact speech and language therapy and the wider kind of therapy team had on you, and just a little bit about your experience. Be great. It was so nice to see you.
Hi, yeah, can everyone hear me all right?
Yeah.
So I'm Sophie, and my son is Xander. We, as nutshell as we can give it to you, I went into labour at 31 weeks after a placental abruption. I had an emergency C-section, and Xander suffered a grade 3 HIE brain injury at birth, and we were admitted into NICU. So that is our very short, snappy journey into NICU at King's College. And we are, in terms of our journey, particularly with speech and language, it started almost straight away. Although our involvement with Becca didn't start straight away, it was a couple of weeks in. But in terms of our feeding journey for Xander, from a speech and language point of view, he had an IV to his belly button straight away because he was ventilated, so he was still getting his nourishment via that. Once he was off of the ventilator, unfortunately, he aspirated on some milk quite early, and it was in the really early days that he had to be switched over to an NG tube down his nose, and he was fed via the NG tube, which is really how his real feeding journey began, and lasted for quite a long time. And it was at this point that we were then introduced to Becca, who was our personal speech and language therapist on the unit, along with many other families. And initially, it was a very sort of introductory level, because in the really early days, Xander was still terribly unwell. And there was a good few weeks where they were clear that they weren't sure whether he was going to make it out of the unit or not. So his feeding journey was a part of it, but it definitely wasn't a priority in the really early days. But we were lucky enough to have the option to meet Becca and her team really early, so we at least knew who everybody was. So we didn't get any surprises later on, which was great. Becca introduced bottle teats and dummy dips alongside his NG tube for us really early. So we were really early able to do that. And these were particularly important for me because it meant that I got to feed my baby how I had imagined for the first time in probably 2 months of him being alive. It was a moment that I got to be able to feed him in the way that I was supposed to. And for us, that was a big part of our speech and language journey. I think we'll go into later on a little bit more of the sort of detail of that journey. But the last bit I'd say is that we worked together to get Xander as much practice with his bottle and his bottle teats. And Becca encouraged the nurses to let me use my own milk, which was a big deal. And it just harps onto a point you made earlier about mums and their journey and their own milk. So even though my breastfeeding journey wasn't one that was in any way, shape or form like it should have been, there was still a part of it that I still got to, take a bit of authority over. So Becca made sure that the nurses knew that I was allowed to use my own milk for those things, and it was set as standard before we carried on with our journey. But yeah, I'm sure we can factor in the rest of our journey into some of your questions later on.
Thank you so much. Yeah, thank you. It means a lot to have you here today, and I think it just really helps us understand more about the real impact of speech and language therapy on a real life situation. So we're really, really grateful for your time and for sticking around and giving kind of your own thoughts as well on some of these questions that we ask. So we're really grateful. Thank you. I think a lot of what you just shared, Sophie, really highlights some of the family integrated care pieces that an ethos of care that we really want to be kind of encouraging as much as possible, and highlights what a significant role speech and language therapy has in that. So kind of my next question was actually going to be along those lines, and I think it would be really helpful to understand a bit more about how you, Alex, and Rebecca, you think that your roles particularly can support parents to be partners in their baby's care. Sophie gave us a really lovely example there. I wonder whether you want to kind of share any more about that on the neonatal unit and maybe kind of at home as well.
Okay, shall I go first? Sophie, you can chip in if too. You've already given me a lovely example. I feel like I need to write it down so I don't forget. But you know, when we think about be supporting parents to be partners in their baby's care, like 3 things basically come to mind for me. So, you know, the neonatal team, SLT included, we need to make parents feel welcome, and they need to feel that they are part of the team, that they are integral, and to, you know, that they're involved in all of their baby's decisions as well, and that you've got that real collaborative care. And also it makes me think of the need for parents to feel informed about their baby's care, because we know from parents that they find this empowering. And so, right, now I'll try and remember the example. So I suppose if we just think about that kind of welcoming, really, as an SLT, you want to make the connections with the families really early on in the journey. It doesn't matter if they're not suck feeding, because we know actually we need to just think about a baby's feeding development. They're doing that last part of their development on the neonatal unit. And so we need to be just thinking, like, how do we support this baby's development? And that's where SLTs will come in and make those early connections with families. And that's what you said, Sophie. You know, Xander wasn't necessarily feeding at that point, but you made that kind of connection, that you build those relationships early on. And what we know as well is that when we take this relationship based care kind of approach, that it means that later on, if like you together, the speech therapist and the parent, experience some feeding hurdles, I'll call them, it's much easier to resolve those together, because you've already built the relationship, and you're not coming in at the point when a problem's been identified. You'll have had some lovely moments doing developmental stuff as well. Like you say, you have some really kind of nice moments about when you took ownership over being able to give Xander your milk. And those things they're so important, aren't they? And they're just like the foundations of everything. We're kind of sharing information about the baby's development, speech, language, feeding development, because we want parents to know that they are so key to their baby's development. They're the most important person. They're going to have the biggest impact. And it's really about us imparting that information with parents so that they can see what positive impact they can have on the baby's development. And I'd say just lastly, that kind of collaboration, it's really, and helping parents, or ensuring parents feel that they're involved in their baby's decision making. I'm going to go back to that one about using your own milk. That's a conversation you'll have had together, you know, and it might be like on ward rounds where you all come together, and it's a real focus on making decisions with parents and as a team, thinking really holistically about the baby. So to me, that's what it means to help parents be partners in their baby's care for SLTs. I don't know whether any of that resonates, Sophie.
Yeah, absolutely. We received more meaningful support from the therapist teams than we did from all of our medical teams combined. And we were in NICU for 6 months. And I can say wholeheartedly that we received more meaningful support from the probably 3 individual people that provided our therapies than we did from every medical person we'd had in there. And what I mean by meaningful is that both our physio, but more so our speech and language therapist, was able to champion our involvement really early. So I was allowed to take the lead on his everyday therapy. They set up systems on the unit that I could use when they weren't there or when they were seeing other families. So something as simple as a printed and laminated personalised speech and language programme. So the nurses could see what the expectations are for dummy dips or lack of them, or bottles or lack of them. So it was very clear, no matter which nurse was on, I didn't have to panic about handover happening or not happening, you know, which happens quite often. But you had to have something there from the speech and language point of view that meant that anyone could access it. Whether it was me doing it, the nurses, it was clear, it was precise, and I didn't have to panic about it. It was one thing I didn't have to worry about when I walked out of the door, that someone was going to feed him wrong. And as well as that, they were able to set up key equipment for me. So it might have been something like a privacy screen to give me a bit of, you know, privacy around our cot. Or foam floor mats for us to be able to sit and do something. Or Becca made sure we had special individualised bottle teats that Xander had for a much younger baby, even though he was older, because the way his oropharyngeal dysphasia worked is that we needed to be very careful about what he had. But yeah, just to agree with everything you said, absolutely.
Brilliant, thank you. I think, yeah, it's hugely helpful to see how that working together, like family and kind of clinical staff, therapy staff, makes such a massive difference. So thank you for sharing a bit more about that that experience. I think, Alex, there was another post that you shared with me, which was about cue-paced feeding, which I'm happy to pop in the chat as well. Was there anything in particular you wanted to share about that at this point?
Yeah, I suppose, well, maybe that ties in with just that support. Becca talked about it, and it ties in with relationship-based care, really. So it's empowering parents by helping them to understand their baby's cues. These are basically the foundations for their feeding relationship. They're able to understand how the baby looks when things are going good, how the baby looks when, you know, the baby's challenged, and they build their confidence by doing this. So it's feeding decisions based on the baby. The baby leads the show, and parents who have that experience have shared with us that, you know, they take that confidence with them when they go home. They know that if there's a blip at home, what that looks like, and they've also learned how to kind of respond in those, because it's not just about showing the baby when they're ready or when it's time to finish the feed. It's kind of what it looks like all the way through. So we've got a lovely poster developed by Katie Parnell and I think Natalie Madden, and we thought we'd pop that in the chat too. We've got posters galore today and we're happy to share them. We love visuals. Yeah, and so I think it really is just that so I can see the bits of the people chatting, their comments, and I think we've probably got some lovely things in the chat to just reinforce some of those things that we've said already. But it's basically just the foundation of learning about your baby and letting your baby lead.
Lovely, thank you very much for clarifying that. Classically, having difficulty myself popping that poster in the chat, but what I'll do, because I think it's an image, is I'll pop it into the I'm going to send round an email after this, which I'll talk about at the end, with the recording, etc. in there. So I'll pop it in there as long as you're comfortable with that, just so that everybody can see that afterwards, if that's okay. Brilliant.
I think I might be able to do it, actually.
Feel free to have a go. No. It might be that I've reached my quota with the other two. I don't know why. So brilliant, thank you. I think there have been a couple of comments that have come through, which we definitely will try to get to. But I think there was just another question that I think really highlights some of the kind of extends some of the things that have already been mentioned about kind of good examples of AHP, MDT, joined up practice, and kind of whether you've got any particularly good examples of how that might work. And I think, Sophie, you just alluded to the fact that there was some consistency around how with Xander's care, the different therapy teams are working together. So I just wonder whether between you'd be happy to kind of share a bit more about kind of good practice and what that might look like kind of when those teams are available on neonatal units. And then we have a question a bit about what happens when they're not. So if we could start with what happens when they are and kind of working together really well, that would be brilliant. Rebecca, I don't know whether you want to start with that initially.
Yeah, I mean, as you've already kind of alluded to, Chelsea, it does depend on how much speech and language therapy or any therapy you have in the unit as to kind of how able you are to work in that kind of collaborative way. I think, we're really lucky on the unit that I work on where we've got a fully staffed neonatal therapy team. And so a lot of what we do is very much kind of joint, really collaborative and embedded within the neonatal unit, not only within the kind of therapy, but within, as kind of Sophie's already kind of suggested, we work really closely with the medical team, really closely with the nursing team, and we are very much embedded within. And so we're seen as that kind of core as opposed to kind of the periphery, which is great. And that's because we've got a fully kind of functioning team, and then we're able to kind of do that on a daily basis in every point. Examples of where we work really nicely as a therapy team are things like ward rounds, which I've already talked about, kind of developmental care ward rounds. We work as a kind of multi-therapy team alongside the nurses and the doctor. We have a doctor that kind of comes with us on every ward round, and a nurse and a speech therapist, OT, physio, lactation consultant. It's very joined up, which is really great. QI projects are another area that we're always kind of looking at how we can kind of review and develop our services. We have a neurodevelopmental follow-up service on the unit that I work at. So we follow our babies up from kind of discharge up until they're 2, and we see them at different points. And so we're reviewing that at the moment as a team, thinking about, are we seeing them at the appropriate times, with the appropriate people, and making sure that we're kind of meeting the needs that parents and their babies want. So we're not only we're actually kind of superseding what the recommendations are at the moment, but we're still checking in with the parents. Is this enough? Do you need more? Do you need it to be changed? So that's something that we as a team are doing as well, thinking about how we can improve our services. And one of the key things, and I remember this, and maybe Sophie can give her reflections on this, one of the key things that we do on the neonatal unit is a developmental pathway, and that's very much a multidisciplinary pathway. So we're all kind of looking at this baby in a holistic way and kind of all coming from our own viewpoints to kind of think about how we can support the baby. So it might be that our OT colleagues will support in terms of making sure that baby's in a really calm and settled state, and then our physiotherapy team will come in and make sure that we're getting baby in an optimum position so that we can then work on early communication. And we're kind of looking at it all together so that parents such as Sophie have one kind of activity that they're doing with their baby, as opposed to the speech therapy and the OT and the physio. We're coming together, we're having a joined up program so that there's a set of things that Sophie needs to do on a daily basis, but that it's not kind of overwhelming, because I think it can be overwhelming if you're given, as lovely as the laminating sheets are, if you're giving 20, it can be a bit like, okay, and when do I just be a mum? And we are very conscious of that as a therapy team. So we're making sure that we build it into kind of daily living, and then it's not so overwhelming. I don't know if you remember that, Sophie, or have any comments on that.
Yeah, absolutely. Yeah, we very regularly used to get 2 different of the sort of specialties from our therapy teams come to see us at once, which was great. So it also meant that we didn't then have separate appointments with everyone, taken away from that time of being a mum. But often so many of them complemented each other. It was important for the physio to be there so that he was in a good enough position to do his speech and language program, for example. So there were so many bits that tied in together nicely if people made the time and effort to do it. Sometimes it was a 5-minute conversation, but it made a big difference.
Thank you both so much. I think that's given a much kind of broader picture. And we, as I said, I would appreciate that that's not the case for every neonatal unit. And actually, one of the questions that we've had through is about the staffing standards. I think that you mentioned at the beginning, Alex, and like the specific SLT ones. I wonder whether there's a link to those that we could also include in the email after today, so that everybody's also seen those, if that's all right.
Yeah, absolutely. And I can see somebody's really helpfully replied in the chat on our behalf about, the role of the network, your network speech and language therapist. So, they'll have an overview of where the gaps are in provision in your area. and then they'll be working with those neonatal units to talk about, you know, what are your priorities, because obviously there's a whole heap of therapies, it's not just us, so but what are your priorities as a unit? And then if SLT is a particular need, there's a shortage, as you've mentioned in the chat, then really facilitating and supporting the neonatal team to think about how they're going to grow their SLT team. So that really is the role of the network team and the network lead.
Lovely, thank you. So yeah, hope that's helpful, and I'm sure like there's opportunity to share contact details and that sort of thing if you're not sure who your network lead is as well. So do kind of reach out to other colleagues or to us, and we can try and signpost you to the right place. Brilliant, thank you. We've also had a comment, Sophie, I hope you don't mind me putting you slightly on the spot, but someone has asked in the chat whether there was anything else specifically about your experience that really made the difference for you and for Xander while you were on the neonatal unit. I think obviously we're talking about speech and language therapy today, but if there was kind of even more broadly than that, I think it's helpful for us to kind of understand that.
There definitely is. And I think there was a question we might cover later on about assessments, and I think I'll steal my answer from then, so I won't answer later
Go for
on.
it.
But, one of the sort of next step in our journey, so we've got up to where we Xander had an NG tube, and we were feeding him a very limited amount in a bottle tea, and we were sort of practicing that as much as possible. So the next step for us is we had a video fluoroscopy, which showed that despite all of our hard work, Xander wasn't swallowing safely. And we couldn't continue the feeding journey in the same way that we'd started it. And it absolutely broke me in half. Tore me about. I was convinced we'd cracked it. And Becca had to be the person who not only had to deliver that news after us working together so closely for months on end on this, but had to be the person who had to, after I'd asked lots of very difficult questions, had to be honest and say that she hadn't personally worked with anybody or any children that had Xander's level of oropharyngeal dysphagia that went on to eat meaningfully outside of tasters. And that bit of information was probably, still sits with me, you know, being able to reel it off in the way that I can shows you how much it sits with me. But that was a big turning point for us in having to come to terms with his feeding journey, because up until then I was very much gung-ho of the view that no, we'll figure it out. It's just going to take some time. You need to wait until he's not premature. Then you need to just wait until he's, you know. And there was always another milestone or, you know, inch stone that I used to try and set for when we would be able to make that call. But that scan drew a line in the sand for us, so it meant that we had to think of longer term options for him. And he had eventually had a gastrostomy, and he had a peg fitted when he was about 4 months old, which allowed us to feed him sort of directly into his belly. And it also meant that Becca was there to make sure that I still received the support on the unit from the nurses about making sure I still gave him dummy dips. I was still encouraged to try and do as much of the safe parts of the journey we'd done already, but also learn a whole new journey in terms of feeding him in a way that we hadn't expected, you know. And it was still our feeding journey, and it still is his feeding journey, but it was a very different one, and it was one that then turned more medical than we had hoped it would. But it also meant that the feeding support on the unit, and particularly our support from Becca, changed and focused more on speech and communication, and it filled a void that I had from the feeding sessions, because then I had something else to do, because now I had something to focus on to get him babbling, to get him communicating. So we were able, you know, Becca was able to swivel really quickly when I needed somebody to give me a bit more purpose again, because I was lost. And from that point on, our transition to our community speech and language was seamless. We were the first professional that came to see me when I was at home was our speech and language with our dietitian. I think they came on Christmas Eve or 2 days after, something along the lines. It has been the same woman ever since. She champions him as hard as Becca did. And she has been consistent with us since then. And just our last point is that we have now slightly changed Becca's statistics as well, because we've managed to get to the point where Xander eats twice a day. He eats pureed food twice a day, so he has breakfast and dinner, as well as his milk, and he's obsessed with food. If you can get him near an ice pole, you'd be a better woman than me to get him away from it. So we've been able to flip some of that on his head as well, which is nice. But yeah, so that's our current journey in terms of feeding Xander and how that links in.
Thank you so much, Sophie. I think yeah, hugely moving to hear about the kind of different challenges that you've faced and how you've overcome them as a family and with the support of the therapy team. So thank you so much for sharing that. Some lovely comments from people in the chat as well about saying how grateful they are to hear more about that experience and what really made a difference to you as well, because that's always what we're trying to do, like we're trying to kind of think about ways to kind of improve these experiences and really focus on the baby and the family. So thank you. Brilliant. I think we've covered loads. I think we've probably got time for one more question. I'll keep a quick eye on the Q&A in case there's any last minute bits. But I just wanted to kind of ask whether there was anything else about speech and language therapy, any unique aspects about this particular role on the neonatal unit or beyond and kind of within that ODN kind of specialty that you would like, Alex and Rebecca, you would like to share with us today before we close. I think we've heard, yeah, a load, but I think it's nice to kind of hear from you whether there's anything else that we've missed.
And I think we're so fortunate to have Sophie, who's so articulately kind of described her journey and already touched on a lot of the kind of different parts from your perspective, which is the most important one. So we'll just add to your story so far. Becky, feel free to chip in with this one. I suppose it's just to highlight or reinforce that you know, as neonatal speech and language therapists, our specialism lies in feeding and swallowing, and also the kind of the hint is in the title, speech and language, and communication. And so that is our kind of area of specialism. That is where we've had our training, and that is what we bring to babies and families when we're at the cot side and we're carrying out our clinical assessments. You know, when we do clinical assessments, they're individualized. They should be carried out with the parent and also with the nurse as well, because you know, all these kind of plans and decisions and observations can be made collaboratively. And we're looking at skills before, you know, lots of babies, they have to wait a long time before they start to suck feed. And the neonatal speech and language therapist is going to be really looking at those, what we call pre-feeding skills as well. And so, yeah, that is like a large component of our assessment. We might use auscultation at the cot side, so you might see a neonatal speech and language therapist with a stethoscope, and that's basically just part of their assessment as well, their assessment tool. And I'm sure again they'll be happy to go in depth about you know, how that helps their assessment if you were to ask them. Yeah, basically if we need more information as well as our cot side assessment, then we can rely on the kind of gold standard, what we call an instrumental assessment. So it's like an objective measure of the swallow, and that is what Sophie experienced with the video fluoroscopy swallow study. And we've also got another one, the fiber optic, snappy title, it's actually called FEES, that's much easier, but it's fiber optic endoscopic evaluation of swallowing as well. And so, you know, we have these other instrumental assessments that we can use. However, they're generally used for a really small cohort of babies, so it's worth just adding that as well. They're the babies who are term, the bigger babies, but it's just a tool, I suppose, in our toolbox if we need to find out a little bit more about what's going on with the swallow. Becca, is there anything that you want to add there?
No, I think you pretty much covered it all. I guess, I mean, our main role is around kind of supporting kind of feeding, communication and swallowing. But I think what Sophie, you know, I think the reason Sophie had such a positive experience was because we were very much embedded within the neonatal team, within the neonatal unit and within the neonatal team. And I think that's what really makes the difference. And I know, you know, if you're kind of limited in terms of your kind of resource, that can be really difficult. But I think it's very much kind of worth putting that time and effort in to kind of really kind of develop those relationships with the people on the ground, because it can make such a difference. It might just be the difference between kind of, you know, people kind of knowing to look for your feeding plans and things like that. I think because we were a part of that team, it meant that the nursing staff at the beginning of a shift know, does this baby have a speech and language therapy program that I need to be following, you know? And I think, you know, that's key, just making sure that you kind of develop those relationships, you're embedded within the team as much as possible and as much as your kind of resource allows you to. Because I think that when we all work together as a team, then we get much better outcomes for our babies and the families that we're supporting.
And I suppose just a finishing line would be that all of that is possible when you have more SLT time. So, you know, if it was how we're talking, if that looks very different to what happens on your unit, it might relate to the time that the speech and language therapist has. Because you would have to kind of prioritize and do the very most important thing first if you've got very little time. So we're able to work more holistically in that multidisciplinary way. We're able to focus on the speech and language development as well as the feeding and the swallowing, and that's exactly what Sophie described in her experience today. Thank you, Sophie.
Yeah, just to reiterate, thank you.
You're welcome. Thank you for having me.
It's definitely our pleasure. Thank you all so much for your time. I think obviously couldn't do the session without you being the absolute experts, and obviously hearing kind of more about Sophie's experience has been really, really powerful. So huge thank you from us for your time, and to everyone who has joined us today or is watching back. Hope you found it a really useful session, as I definitely have. Just to kind of summarize from our side, we will be sending out, I think I've alluded to already, an email just with the recording from today, as well as kind of a couple of the things. I think we'll try and include those staffing standard links and the poster that I couldn't get the tech to work on, so we'll pop that in as well. There's opportunity to provide a little bit of feedback about today's session, just so that we can continually try and improve what we're doing for you as healthcare professionals in this sort of sphere. Please do respond to that, just so that I can make sure that these events are as good as they can be. And there's opportunity to get a little certificate as well to say that you attended today, if you pop your email address in after the feedback. We have mentioned already that this is part of a series. This is the fourth session, so we have 3 others. The recordings are available on our website, so please do, if you haven't had time to kind of take a look at those, please do as and when you can. We hope they're really useful for kind of just solidifying your own understanding, but also kind of please use them for kind of training of other members of staff if people aren't sure about the different specialisms and what roles they might have within the neonatal unit. We hope there'll be really useful sessions for that as well. And we do have more coming, so we have a couple more planned for September. We're going to pause now before the summer as everybody goes off on lovely holidays, I'm sure, and then start again in the summer. In September. So please do sign up, register interest. All the information again will be linked through in that email that we'll send across later on. So we really hope to see you there. And I think kind of last but not least, I wanted to just kind of mention we've lots of different elements of kind of, we've talked about BFI in lots of different ways, but I think also it'd be amiss of me not to mention the Bliss Baby Charter. There's a big feeding section within there, but also just wider kind of specialist teams and how teams work together. So please do kind of use any learnings that you've got from this to think a bit about maybe some of those if you're working on that audit tool as well. We hope that will be a useful thing to think a bit about that as well. So I think that is everything from me. I don't know, I think I have just double checked that there's nothing more from Alex, Rebecca or Sophie before we close.
No.
Thank you. I think we're all talked out.
Yeah. Yeah, it speeds by, but there's a lot to cover, so I'm really grateful for all of being really concise and getting through all of that. There was loads in there, so yeah, brilliant. Thank you everybody, and enjoy the rest of your day. Take care.
Take care.
Take care.
Bye.
Thank you.
Bye-bye.
Bye.